Assalamu alaikum. Today's lecture is about indication and types of extracorporeal CO2 removal. It's a second lecture for this modality of treatment, as there is no clear guidelines, so it's based on expert view recommendation for this line of treatment. In ECCO2R system, the gas exchange membrane is a device with hollow fibers. The material used is polymethyl pentine, and the gas exchange surface varying in the size from 0.32 to 0.65 meters square for venous and 1.3 meters square for arteriovenous. Circuits such as membrane are coated with heparin for better biocompatibility. In different type of ECCO2R, there is a pumpless EV system. There is no pump, so it's EV system, or a pump with a membrane, they are in series, or pump integrated with the membrane into the membrane, or the pump with the membrane, they are part for CRRT system. ECCO2R system, there is early VV ECMO, which is surgically inserted large bore venous cannula, and the priming volume about 2000 ml. The membrane is silicone, 8 meter square surface, and the flow rate 2 to 4 liter per minute, and uncertain benefit due to large amount of blood loss. But if we come for EV ECCO2R, it's percutaneous arterial 13 to 15 French, and the venous is 15 to 17 French. The circuit volume, priming volume is 350 ml, and polymethyl pentine 1.3 meters square, and the flow rate is 1 to 2 liter per minute, and the target INR 1.5 to 2 in this patient. There is significant complication related to arterial cannula, and this needs specialized center. For modern ECCO2R type, the percutaneous double lumen cannula can be used, which is DCAP 14 French, or ILA active, which is 18 to 24 French. And the priming surface is 500. Polymethyl pentine is the oxygenator membrane properties, and the approximate flow for DCAP will be less than half liter per minute. For ILA active, it's varying from 0.5 to 4.5 liter per minute. Target INR 1.1 to 1.7 INR. There is lack of supportive evidence at present till now. The first type of ECCO2R is EV ECCO2R, which arteriovenous extracorporeal CO2 removal. It's pumpless system. Mean arterial blood pressure is 60 to 80 millimeter mercury. The patient will not be in heart failure. Membrane lung should have lower resistance, as the transmission from arterial side to the venous side will depend on the arterial pressure, mean arterial blood pressure of the patient. For VV ECCO2R, divided in two types. Low flow system, which is derived from renal replacement therapy with roller pump, and high flow system derived from ECMO, which has centrifugal pump. There are two types of ECCO2R system. One derived from a high flow VV ECMO. So the pump is used as centrifugal pump, and the flow can ranging from 500 to 100 to 1,500 ml per minute, 1,000 ml per minute, and the CO2 removed from up to 150 to 180 ml per minute, about 50% of total CO2. The catheter use double lumen, it's 23 French catheter, or two small single lumen catheter is 13 to 15 French. The lowest surface with the highest blood velocity with optimal design, lung membrane is about 0.8 to 1 meter square. And the pump derived from renal replacement therapy, it's a rural pump, the flow ranging from 250 to 500 ml per minute, and the CO2 removed up to 80 ml per minute, about 20 to 30% of total CO2. And the catheter used is double lumen for about 11 and 16 French, and the lowest possible surface area with highest velocity and optimal design of the lung membrane is 0.4 to 0.8 meters square. This picture summarizing the indication if we need to use low tidal volume ventilation, so we can use ECCO2R. If we need to extubate the patient, and we can use ECCO2R to facilitate the extubation. Bridge lung transplant, and to avoid prolonged intubation. Prevent intubation and patient COPD, so we can use ECCO2R as an adding device. It can be used in patients with COPD during expiration or during non-invasive or invasive mechanical ventilation to facilitate weaning from mechanical ventilation. It can be used in patients with ERTS or a patient who are waiting for lung transplant. In COPD patient with the ECCO2R can be used to decrease respiratory drive, decrease respiratory rate, and increase expiratory time. All of these will decrease dynamic hyperinflation and decrease muscle fatigue. Both of them will decrease CO2 elimination and decrease CO2 production and correcting respiratory acidosis. All of that were reflecting on increase the right heart function and decrease the pulmonary hypertension. So if we go for patient who COPD already intubated, patient who not extubated early without ECCO2R, previous intubation for exacerbated COPD, had failed continuous breathing trial due to increased dyspnea, reintubation after extubation attempt despite non-invasive, patients with severe bronchospasm who are difficult to ventilate adequately, patients who remain hypercapnic and not improved with mechanical ventilation, so no hypoxia to prevent extubation, mechanical ventilation less than 72 hours, patient with whom in IV with good quality of the life. If we come for ERDS patient, what the initiation criteria to use ECCO2R for patient having driving pressure more than 14, plateau pressure more than 25, which is against the ERDS network recommendation, and BCO2 more than 16 to 18 millimeter mercury, pH less than 7.25, and respiratory rate more than 25 to 30 to 30, VO2 to FiO2 100 to 200. Treatment target driving pressure should be less than 14, and plateau pressure less than 25, and respiratory rate less than 25, and pH more than 7.3, tidal volume less than 6 ml ideal body weight, and BCO2 less than 50 to 55 millimeter mercury. Weaning criteria and steps for weaning for ECCO2R in ERDS patient. ECCO2R will apply it for at least 48 hours. VO2 or FiO2 more than 200 millimeter mercury before testing weaning possibility. Set tidal volume 6 ml per predicted body weight, and PEEP 5 to 10 centimeter water. Driving pressure less than 14, and respiratory 20 to 30 breaths per minute. Decrease gas flow to 0, and using 2 liter per minute decremental step. And while weaning, pH should be remain more than 7.3, and respiratory rate less than 25 breaths per minute. Patient will be weaned off ECCO2R after minimum 12 hours of stability under the setting of pH more than 7.3, and the respiratory rate less than 25 breaths per minute. Summary for recommendation for clinical practice of ECCO2R. Use central catheter with ultrasound guided and septic placement. Consider VV ECCO more over EV ECCO. Avoid EV core under center outside centers familiar with this technology. Seek alternative treatment option for patients who are unable to receive anticoagulation. Regular monitoring for anticoagulation and cease the therapy in case of clinically significant bleeding concern. In patients with acute hypoxemic respiratory failure, there is no insufficient recommendation for the routine use of ECCO. For acute hypercapnic respiratory failure, further data is needed to consider ECCO as a standard treatment. Selective delivery in center using ECCO ensure efficiency in the delivery of continuous renal replacement therapy, ensuring 24-hour availability of ECCO experienced physician, and should have a specific training program in each unit providing ECCO service delivery staff experience in the managing of the patient. Anticoagulation therapy, anti-factor 10 activity between 0.3 and 0.6 international unit per liter is mandatory to avoid thrombosis in the circuit. So any patient with contraindication to anticoagulation therapy cannot benefit from ECCO therapy. Anticoagulation with the intravenous unfractionated heparin, preferably applied to the ECMO. Monitor PTT and anti-factor 10 or both so as to obtain PTT 1.5 to 2 times normal baseline, 45 to 70 second, or anti-factor 10 0.3 to 0.5 international unit per ml. Giving heparin bolus 40 to 80 unit per kg body weight, and bolus not preferred in patient already on full anticoagulation. Bolus routinely performed when guide wires has been inserted or the catheter insertion is banned. Patient with proven HET, we can use agratopan protocol 0.5 to 2 mic per kg per minute. If we go for complication of ECCO, if we have EV ECCO, there is limb ischemia and compartment syndrome, bleeding during cannulation, and this is commonly with arterial side, cannula thrombus. And if we go for VV ECCO, it's more commonly to have cannula thrombosis because both of them are VV, veno-venous cannulas. If we speak about general complication like catheter insertion, will be have at the site of catheter, bleeding, infarction, insertion of arterial instead of VV in ECCO, in veno-venous, catheter displacement or kinking of the tube, hematoma, aneurysm formation, compartmental, as I mentioned before, and distal limb ischemia in EVR. The therapy itself, there will be worsening of hypoxia during lowering of tidal volume ventilation, bleeding due to anticoagulation, hemolysis, and heparin-induced thrombocytopenia, acquired coagulopathy like acquired von Willebrand, air embolism, and recirculation. Device failure like pump failure, oxygenator failure, heat exchange manufacture, clot formation, and air within the circuit. Besides Elsulis Red Book, this is the reference of this lecture. Thanks, and you can put your comment or questions in the down in the comments.